All right. They give you a male infant with recurrent infections and no B cells.
Okay. B cells. So this
What's the most likely diagnosis?
Bruton. Bruton.
Good. Bruton X A gamma globulinemia, right? Bruton X A gamma globulinemia. You remember that these children generally start having infections after about 6 months of age. Why? Why don't they present much earlier? Why do they tend to present around 6 months of age?
Because they have the immunoglobulins from the mother.
Because they have maternal IgG, right? Because they have maternal IgG. They have low B cells and they are going to have recurrent bacterial infections. They are going to have recurrent bacterial infection. Do you get it? Remember that these people may also have enteroviral infections. So, classically, viral infections are associated with T cell deficiency. You remember from your immunology. So, when there's B cell deficiency, you have bacterial infections. When there's T cell deficiencies, you have viral infections and slash fungal infections. When you have neutrophil deficiencies, you have bacterial slash fungal infections. Does that make sense? But remember that your IgA in the gut is protective against infections as well. So people with no B cells tend to get enteroviral infections with enteroviruses. Do you get that?
Okay.
All right. Then you also remember that you have other immunodeficiencies. Which immunodeficiency causes people to have recurrent mycobacterial infections? Recurrent mycobacterial infections. What would that be? Any problems involving interferon gamma, interleukin 12 receptors, right? Interferon.
Is this a very combined deficiency or no?
What do you call? No, this is different from severe combined immunodeficiency, SCID. Severe combined immunodeficiency is interleukin 2 receptor, not 12, right? Interleukin 2 receptor deficiency. This is one form of SCID. Of course, we also have adenosine deaminase deficiency causing SCID, right? We have adenosine deaminase deficiency also causing SCID. Mycobacterial infections have relationship with interferon gamma deficiency or interleukin 12 receptor deficiency. You remember that you need interferon gamma to activate macrophages and form granulomas, and you need TNF alpha to maintain granulomas. You remember that? And that should remind you why anti-TNF alpha medications can lead to exacerbation of TB. Medications like reactivation of TB. Medications like adalimumab, etanercept, infliximab, those anti-TNF alpha medications that you use to treat what? Ulcerative colitis and Crohn's disease. Those medications will result in reactivation of TB because they decrease TNF alpha and therefore you cannot maintain granulomas. Again, if there's interferon gamma deficiency, people will be prone to having mycobacterial infections. Does that make sense? Remember that they can give you someone with recurrent recurrent bacterial infections, but normal B cells. Recurrent bacterial infections, normal B cells number count. Well, let's say B cell count. So what could the problem be? If they told you neutrophil is normal, T cell count is normal, everything else looks normal, but there is recurrent bacterial infection, what could it be with the B cells? This is something called Behr lymphocyte syndrome. I'm not going to want you to stress about Behr lymphocyte syndrome a whole lot here. But remember, Bare lymphocyte syndrome. Bare lymphocyte syndrome is of two types. We have Bare lymphocyte syndrome 1 and 2, and it's basically the absence of MHC molecules. If you have MHC class 1 deficiency, oh, it's actually not B cell. What am I thinking? That would be your T cells.
T
Okay,
cells, yeah.
your T cells. The deficiency in MHC class 1 or MHC class 2. So if you have MHC class 1 deficiency, you have Bare lymphocyte syndrome type 1, or MHC class 2 deficiency, you have Bare lymphocyte syndrome class 2. Remember that CD4 positive T cells are associated with MHC class 2, right? And CD8 positive T cells are associated with MHC class 1. You remember that MHC class 1 is found on all cells except red blood cells, and MHC class 2 is basically found on antigen presenting cells. Do you get that?
Yeah.
All right. They give you a person with muffled heart sounds, distended neck veins, and hypotension. Muffled heart sounds. You should get this immediately. What would that be?
Yeah,
Beck's triads, right?
yeah.
Beck's triad is for what diagnosis?
Cardiac tamponade.
Cardiac tamponade. Very good. Distant heart sounds, JVD, jugular venous distension, and hypotension is the classic Beck's triad, right? What if they give you someone with mucosal bleeding and prolonged bleeding time? Mucosal bleeding.
I was thinking about plaquettes disorder.
Platelet disorder. What comes to mind? If I
Well,
told you the platelet count is sort of normal to decreased, mucosal bleeding. Remember, we have two types of platelet defects, right?
Yes, we have the one that is in the GP1B.
Okay, so you could
Uh,
you talk about GP1B deficiency and what? What this
And
disease
the-
called?
is glams.
Okay, so there's Glanzmann thrombocythemia,
I know that is with B.
right? There's Glanzmann thrombocythemia, and that is GP2B3A deficiency.
Yes, it's the plaquettes they cannot be together.
Yeah, the platelets cannot communicate with one another. So when we talked about wound healing, you talked about platelets using one receptor to communicate with, basically attached to the basement membrane. What was that? GP1B, right? And GP1B interacts with what? Von Willebrand factor, right? And then platelets.
I remember how it's name. Burner.
Bernard-Solier syndrome, very good. Bernard-Solier syndrome. And then platelets interact with other platelets using what receptor? The GP2B3A receptor. And what's the compound between them that allows them to communicate with each other? This guy. Fibrinogen.
APGP.
Fibrinogen. Not ADP. ADP is within the platelets. It's one of the activating compounds inside of the platelets, right? So platelets communicate with each other or form bonds with one another with the help of GP2B3A. Mediating them is fibrinogen, and platelets interact or adhere to the basement membrane with the help of GP1B interacting with von Willebrand factor. Do you get that? So a qualitative defect, whether Bernard-Solier syndrome, GP1B deficiency, or GP2B deficiency with Glanzmann thrombocythemia, will result in abnormality with platelets, resulting in prolonged bleeding time, potentially mucosal bleeding as well, right?
Yeah.
In either of these cases, platelet count will be normal or maybe slightly decreased. Do you get that? All right. They give a person with multiple colonic polyps in the colon, osteomas and soft tissue tumors, and impacted supernumerary teeth, multiple polyps, colon polyps.
It's Pexor,
What did you
is
call
the
it?
familiar of the familiar I don't know.
Okay, it's
And
one
this
of the
is
familial adenomatous polyposis. So which of them would this be?
the Pexor. Mm,
Which one are you trying to talk about?
one that is PTEUS.
Peutz-Jeghers syndrome. Is it really Peutz-Jeghers? In Peutz-Jeghers, you remember this is where you have hyperpigmentation
Mm. Oh, this is Gardner.
of mucosal. Good. This is Gardner's syndrome, right? Polyps with soft tissue tumors and osteomas, so even tumors in the bone, with supernumerary teeth, impacted supernumerary teeth. That would be Gardner's syndrome. Peutz-Jeghers is the same adenomatous polyps, but with hyperpigmented mucosa. You may want to remember that in Peutz-Jeghers syndrome is also where you have those hematomatous polyps, right? It's where you have the hematomatous polyps. And then where do you have neurological symptoms or CNS tumors?
Um,
You remember Tokot syndrome?
cut. Oh, let's just say that's it.
Tokot syndrome. Not very popular on the exam, if you ask me, right? Okay, we've done this like 100 times at this point. A child with glucose deficiency or hypoglycemia, exercise intolerance, and cardiomyopathy, cardiomegaly. What would that be?
Homeopathy is hunger,
A child with cardiomegaly and
no,
hypoglycemia or exercise intolerance.
courage.
Remember that Coris and von Geck are basically like senior and junior brother. Coris disease is the milder one, von Geck is the severe one. These two guys caused hepatomegaly, right? That's the big thing you're looking for. Exercise intolerance and liver, Coris disease, von Geck's disease. Exercise intolerance and heart, Pompey's disease. The pump affects the pump. Exercise intolerance and heart, Pompey's disease. Infantile hypertrophic cardiomyopathy in Pompey's disease. Von Cory's disease, hepatomegaly, mild hepatomegaly. Von Geck disease, severe hepatomegaly with additional findings like acidosis, hyperuricemia, and so on and so forth. Do you get that?
Yeah.
You want to make sure you differentiate them. Cory's disease, von Geck's disease, hepatomegaly. Coris is mild, and you also have limit dextrin in Coris disease. Von Geck is very severe. You have severe hepatomegaly, hyperuricemia, lactic acidosis. And then, of course, Mercado's disease is the one that involves just the muscle in Mercado's disease, right? Do you get that?
Yes. Pompeii is the one who affected.
Pompey's disease is the one that has cardiac involvement. Hypertrophic cardiomyopathy, infantile hypertrophic cardiomyopathy. Pompey's is also the one that is both a lysosomal storage disease and a glycogen storage disease. All right. They give you a neonate with arm paralysis following difficult birth. A neonate. Abduction palsy. Very good. Abduction palsy. What part of the brachial plexus is damaged? What nerve?
Is the upper?
The upper trunk, right? Or the superior trunk. So what nerve is that?
That is axillar muscular
What's the arrangement for the brachial plexus from top to bottom?
Sorry, C5, C6.
Good. So it's C5, C6. It's MARMU, MARMU. From top to bottom, you can remember them in this fashion. So the top is what? Musculocutaneous nerve.
Musculoskeletal.
So that's who is that most likely damaged in abduction palsy. And then you have axillary. And then, of course, radial, median, and ulnar.
Okay.
Do you get that?
Yeah.
So when you pull the child out and you hyperextend the neck, the shoulder neck angle, right? You damage the superior trunk of the brachial plexus. Of course, other forms of injuries can also result in this damage as long as they involve hyperextension of the shoulder neck angle. Do you get that? And then if the child's hand is pulled out during delivery, you pull them by the hand, then you hyperextend the lower part of the brachial plexus.
Yeah.
What do we call that?
Lumbar.
Plum case palsy. You damage the ulnar nerve, right?
Yeah.
You damage the ulnar nerve. These people with abduction palsy are the ones that would present with Wetter's tip, right?